All right. Good afternoon, folks. We have a few people already in attendance, so we'll get started. This topic is on sleep apnea evaluation and testing. This is the third out of a series of 5 that we're hosting to get information about sleep more readily available to other practitioners who are not primary sleep practitioners themselves, other subspecialties, even general public, whoever's interested. This is a series of 3 we had. Out of 5, we had the last one, insomnia, a month ago. The one following up is going to be a month from now on April 14th. So keep that date saved. Similar time at 12:30 p.m. Eastern time, and that will be on sleep apnea testing, treatment and management. So we kind of talk about the troubleshooting tips and so on related to sleep apnea and the treatment related to whether it's CPAP and all the other modalities. And probably later in the year, we're going to host a series of webinars focused on pulmonary medicine as well, the basics and trying to understand and so on, just so that you're comfortable with it. This is a disclaimer, use your clinical judgment, but I'm more than happy to act as a phone a friend option or someone that you can call or email. So this email I'll share at the end of the, just feel free to shoot me an email. And if you have any questions, feel free to kind of reach out at any point. For those who've seen this before, I apologize. We have to keep showing you this. Again, just to prove that I'm not a snake oil salesman. I'm fellowship trained, been in practice now for coming up to 8 years after 7 years of postgraduate training, which is long, but I'm grateful I went through it and the mentors I've met. Now, we've also founded, I founded the first virtual integrated sleep and pulmonary practice that's and so what we do is we do everything from evaluation and testing and treatment in patients. So that's the integrated part. The virtual part is we actually don't have a physical location. So we're location agnostic. I'm licensed in several states, including South Carolina, Virginia, Florida, Minnesota, Oklahoma, Texas, and I'm losing track, Georgia for sure, Florida as well. Waiting on licensure in Arizona, California, and New York soon. All right. This was created by me, but again, nothing is created out of a vacuum. I have to thank my mentors who have taught me really well, but also the American Academy of Sleep Medicine, who I'm a member of, and they have great resources to help spread the good word on sleep. You'll get education credit. So how it'll work is you will, after this webinar is over, I was going to say show, but after the webinar is over, we will then send out within a few hours post-test evaluation. One will be an evaluation of the activity itself, and the second one is an actual post-test for the webinar, through which you can get credits from the American Association of Nurse Practitioners. You'll need to complete that, and that closes the due date of that closes a week from now. When we do send you that, there will be a video as well. So if you have to hop off this quickly for whatever reason, and I understand it's the middle of a workday, you can always review the video and then answer the questions to get your credits. People who have registered, if they can't even join us, as long as they've registered, they can watch the video for that 1 week that we allow it for the test to be submitted. And once the test deadline closes next week, give us roughly a week to do the test results and collate all of that along with sending out the certificates. So give us 2 weeks from today to receive your certificates, and feel free to reach out if you don't hear from us. We don't want anyone not to pass this. So sometimes when there are questions that are not clear, I'll go ahead and exempt that, but we will send out retests if you don't meet the criteria of the 70% passing rate. Again, it's all about education here. We're not trying to get people to pass or fail. So let's get started. We're going to talk about sleep apnea, which is really the bread and butter of a lot of sleep physicians. Now, we don't, the sleep apnea of the prototypical obese male, loud snorer, freight train snoring is I would say a 5-year-old can diagnose that. This is talking a little bit more about how it affects different patient populations and seeing how we may be missing a large number of patients because they don't fit that mold that we're used to of how we were taught or what we think of as sleep apnea patients. So the objective here is to understand how sleep apnea affects us in terms of what it does to our health, how to assess for it, meaning that what words do patients use, how they describe the issues, then recognizing some of these issues in patients based on their comorbidities, based on their other medical problems. And then following that, what testing options do we have? And what can we look forward to? What are the pros and cons of each? All right. So sleep apnea occurs, it's not wake apnea. And so it occurs when you have sleep. And so what happens when you are falling asleep, just like all your musculature in your body gets more relaxed and tends to lose its tone, your airway muscles also tend to get floppier and more likely to be collapsible. When you have sleep onset and you lose that airway collapse in patients who have a predisposition to sleep apnea, the airway collapses, they have the apneic episode, you will see the oxygen levels drop soon after within a few seconds. The body's trying to break through the obstruction. So you'll see some respiratory effort on the chest wall belt and so on. I'll show you that a little bit longer in a little bit. And then that causes the brain to go, hey, wake up, you're choking. And so it releases a flush of hormones. Your sympathetic nervous system is activated. There's an arousal. Now, the arousal over here, most of the time, kind of like an iceberg model. The arousals that patients are aware of, meaning that I wake up 5 times a night, I wake up 6 times a night, is only at the tip of the iceberg. If you ask their bed partner or their spouse, they'll tell you that the breathing events occur so often and there's this snorting and gasping throughout the time. So in actual fact, even though I've listed the arousal, it's micro arousals that causes the sleep fragmentation. Now, when the patient has an arousal, that also causes their muscles to increase in their tone, and that gives the airway more their caliber again, so the airway opens up again. And then patients try to correct that hypoxia and so on by hyperventilating. So you have two mechanisms really, and I'll talk about here. So it just as you are falling asleep, you will see the complaints commonly of when I'm falling asleep, I can't go to sleep, and I have to watch TV until I'm so exhausted, or I need medication to help me fall asleep. It's because as they're falling asleep and their muscles relax, they go apneic and then they wake up again. So they have this idea that they actually haven't gone to sleep yet. In actual fact, they were trying to sleep, but because of the airway closure, they opened up again. The sympathetic drive is what we'll talk about next, is where you get a lot more of the cardiovascular, the hypertensive issues, the blood pressure, blood glucose control, all these issues, the refluxing as well that occurs as part of some of the sympathetic drive that occurs in some of these patients. The sleep fragmentation, so that's related to the microarousals or the arousals itself, that does not allow you, instead of going to sleep and getting to deep restorative sleep and then waking up kind of bright-eyed and bushy-tailed, most patients have this multiple nocturnal awakening over and over and over again at night. So when they wake up in the morning, essentially they've had, even though it looks like on the clock they've had 7 hours of sleep, essentially effectively they had 2 or 3 hours of sleep. So imagine compounding that over months, weeks to months to years, and you can imagine how it affects someone's health. The neurocognitive effects as well, kind of the pseudo-dementias and pseudo-depressions I'll talk about as well, is probably related to the hypoxia and the sleep fragmentation. So we're not sure which one more, but both of them seem to be equally at risk. The hypoxia and so on drives a lot of the cardiovascular issues, and also the sympathetic drive. Now, what's the damage really? How many are we talking about? So as we see the the obesity epidemic increasing, you see sleep apnea as well tracking that very easily. Now, there's a lot of theories why, some of us are not that overweight, but a little bit overweight, and why we're at risk. And it has to do with some form of evolution of our jaw and with deposition of fatty tissue in our tongues as well. But we're finding that the prevalence of sleep apnea is actually accelerating with the in concordance with obesity. The data suggests over 30 million people have sleep apnea. 4 to 5 million may have been diagnosed. Now, whether they're getting effectively treated, we'll talk about that a little bit more in our next webinar series on April 14th on treatment and management. But there's a lot more patients out there that we're missing out on, and patients that I will never come across because they never get referred or they never get tested. So the prevalence actually is interesting. I want you to take note of this over here. If you see patients, let's look at the female patients over here, and you will find that the prevalence here is within the ages of 30 to 49 and 50 to 70. So as they grow older, the prevalence increases by at least 3, some studies show even 5 times more increase in females as they age. So there's an aging factor to that, primarily driven by the loss of estrogen when they go through menopause. And that causes a spike in females, especially once they start hitting menopause. And they're the patient population that frequently or most often gets misdiagnosed or overlooked And I'll dive into that a little bit more. And you can also see over here that the preponderance of obesity is not as high as you will find for males over here, even that. So the prototypical freight train, snoring, obese male is only one small piece of this puzzle. We're missing out on a whole lot of patients. As you can see, for males over here from a young age to older age, they don't increase as much as females do. So there's definitely a drive that's more age focused in females compared to males. In males, obesity tends to be a main driver. As you can see over here, how the number of patients here compared to here in terms of males versus females that complain of that. So that's why we tend to forget that. So we looked at male prevalence versus females, and definitely up to the age of 50, males dominate. But after the age of 50, the prevalence is actually very much, so the incidence is about the same. So they start catching up, females start catching up very quickly. Like I said, older females tend to have a larger spike. And we'll talk about after this why we miss out on many female patients. So the next, we kind of looked at the pathophysiology, who it affects and how it affects patients. Next, we'll talk about the assessment of sleep apnea in words that the patients use themselves. Snoring. Usually patients get busted by their bed partner, loud snoring. And you talk about gasping for air. Witness apnea is easy. Once you have that, there's I think a 95% likelihood of testing positive for sleep apnea. So once the spouse says, I've seen him stop breathing, I've seen her stop breathing, or it seems like they're struggling for breath, at that point, you're pretty sure that they have sleep apnea, and all you have to do is just get the test done quickly. What happens is a lot of times the witness apnea may not exist as a form of witnessing because they don't understand what stopping breathing is. What I normally will do, too much to my embarrassment, is I actually have to kind of voice it out, or vocalize it. So I describe that to them. I said, do they sound like, they're, and so that last is actually them opening up the airway and breathing. It's kind of the initial snort and gasp is what they're trying to do to overcome that airway. And so you can see the spouse who maybe they're the telemedicine visit, go, yeah, that's exactly what they sound like. Now, being on a supine position as well is a worsening of the symptoms. Sedating medications, we know that really, the opioids, the benzos, alcohol ingestion. Now, oddly enough, patients tend to self-medicate with alcohol to allow them to fall asleep. What they're trying to do is that, when I described earlier, when your airway collapses and you have that mild awakening, the reason why you wake up is because you have an arousal threshold that's normal, which is that when you have a sort of obstruction or something that irritates you, it's going to wake you up. But the same way that alcohol kind of numbs your senses, so when you drink a lot of alcohol as well, it numbs you or increases your threshold so that you have to be really irritated to be woken up. So then what happens is the apneic episodes may occur, but the patient is able to fall asleep. Now, obviously, the fragmentation of sleep that generally occurs with alcohol down the line, meaning an hour to 2 hours later, is going to bite them in the buttocks. But that's another story for another day. Weight gain is frequent. Patients do have weight gain that may be driving that, but also age as well, like I described in female patients. Now, if someone is snoring 5 years ago and they were tested before, and then they come back to you with the same problems, but now they have all the other medical problems going on, it's okay to retest them. I frequently retest patients just because I'm not sure whether the first study was a false negative, but also I know that as patients age, the same weight, even though the weight has not changed, the same weight in an older body can mean a very different effect as well. Just because we know the musculature that keeps the airway open is also weaker now, and that may cause the airways to collapse more easily with just a little bit of tissue around that. So what else do patients complain about? Sleep being unrefreshing. This is sometimes not the best word to use, because most of the time I had a patient ask me this, like, talked about, it's like, how else do you wake up if you're tired? I mean, you should wake up tired, right? Isn't that what normal sleep is like? And so patients don't have a baseline to compare it to. So that's why I sometimes run into trouble. It's like, when you say sleep refreshing, yeah, sleep is refreshing. But then you kind of ask them, it's like, do you feel like you got a great night's sleep as soon as you open your eyes and you set your feet on the ground? They're like, well, no, it takes me a while to get going. I have to have a shower or a cup of coffee. So that kind of tells you that sleep may not have been as refreshing or regenerating as it should be. They wake up groggy or tired. Disorientation may be a more severe form of that. Incoordination is mental dullness is frequently as well. So that's why they need to get going and so on. Dry mouth and throat, because a lot of the times breathing through the nasal passages may not be adequate. And as they try to inhale, because they have an obstructed airway here, they tend to use their oral airway as well. And that causes the dry throat because you don't have an ability to humidify air that you do through your nasal passages. Grinding is also frequently a associated symptom because of the sympathetic drive. When you have an obstruction, is the same way that patients tend to wake up with palpitations or wake up in a startle because of this sort of the sympathetic flush that occurs. Grinding also occurs because then the muscles, the masseter muscles here, of mastication as well, tend to tense, and that causes the grinding to occur frequently at night. So a lot of dentists as well will pick this up early on. Peeing when they sleep or nocturia is frequent, an area that's misdiagnosed because older men tend to get assumed that it's all prostate problem. But if you ask them about the flow of urine is fine. It's just that they wake up to pee frequently. Women as well tend to get overactive bladder diagnosis. They get they put on antispasmodics as well for the bladder and so on. And again, it usually is related to some form of sleep apnea. The reason is when you have this wild swings of your intrathoracic cavity pressure, meaning that when you have an obstruction, you're trying to that swings of pressure that occurs causes your heart to release a hormone called atrial natriuretic peptide, or it's autodiuresis, and actually makes you want to pee. So frequently when we treat patients with CPAP, we will see the nocturia improve significantly in these patients. They will blame their Lasix that they take at 8 a.m. When you try to explain to them at 2 o'clock in the morning, your Lasix should not be working anymore, or they've tried to cut down on their fluids, they've tried this. The body auto-regulates a lot of that. You want to be hydrated throughout the day. If you're not chugging water at night to go to sleep, but you shouldn't deprive of yourself a glass of water. And the glass of water shouldn't wake you up 2 or 3 times at night either. Headaches are also frequently, I have patients who are frequently on Topamax and a lot of other medications seen by a neurologist, gets evaluated, get MRIs. In actual fact, the headaches, which generally occur in the mornings and tend to get better during the day, are driven by hypercapnia, which causes the headaches. But again, sometimes poor sleep as well can lead to headaches in these patients. Now, I'm not saying that these patients don't have a primary headache issue, but there's likelihood that it may be misdiagnosed it may be misdiagnosed because you haven't diagnosed underlying sleep apnea, or their headaches may be worsened by the fact that they have undiagnosed sleep apnea. So this is what I call the baggage that frequently comes in patients. You're talking about when you see patients after multiple times, there's something that sets in, like what I call pattern recognition. You see these patterns that develop over and over again. You see the same medication list, you see the same comorbidities, you see the same stuff. As patients age, you will see they're very similar now. In younger patient population, you won't find as many patients who have these baggage of multiple comorbidities. In older patients, you'll find the diabetes or pre-diabetes, mental health issues. Oh yeah, I had depression, blah, 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 and I'm on this, I'm on an anxiety medication. Erectile dysfunction, which is interesting because when they get tested for, like, for example, they feel fatigued and then they get tested, maybe they have some symptoms of erectile dysfunction. Sometimes testosterone is also given. Testosterone worsens sleep apnea. So that goes to show that we really have to focus on getting a better sleep history in a lot of, and I'll show you the next slide as well. Will shock you and scare you at the same time, because we really should be focusing on asking a lot more about the sleep when you start seeing a lot of these problems, kind of the baggages that seem to accumulate. Patients that keep, they've swore to you, they've watched their diet, they can't really starve themselves. They can't really restrict. How much of fluid restriction can they, how much of salt restriction can they do? Patients that keep coming back to the hospital, you keep increasing the medication. These are patients that you have to really figure out what is driving or what's fanning the flames of this multi comorbidities that seem to be propping up. Like I said, age and weight go really well until a certain point, and then that weight on an older body causes a lot of these issues, especially if you have weight, if you think about it as a pyramid, and weight is at the bottom of that pyramid at the base. If you have sleep apnea on top of that, that drives a lot more issues in terms of what we're seeing right now. Polycystic ovarian disease as well in patients. You'll see that as a frequent presentation in female patients. Now, hypertension is frequently there, and we'll talk about resistant hypertension, heart failure, poorly controlled heart failure, or unclear reasons for the heart failure to occur. I just, yesterday, I saw a patient who was 26-year-old female who was being evaluated, but she was diagnosed with heart failure 5 years ago and was told she probably had sleep apnea, but no one treated that. And she's on 4 different medications now to control a heart failure. She's on disability. She can't move around. And so, a part of the reason was trying to explain to her how sleep apnea may be causing a lot of this. Strokes as well, either is driven by changes in the arterial system because of the sleep apnea itself, the hypoxic drive and the repetitive sort of hypoxic changes, but also driven by atrial fibrillation and all other coronary vessel disease or CVDs. Atrial fibrillation also occurs frequently. Bradycardia as well. You'll find, especially if you're hospital-based, you may come across a lot of patients that they're bradycardic, and then you end up calling electrophysiology and they kind of go through $1 million workup. But in the bradycardia, especially at night, that should be a concern for sleep apnea. There's something called a diving reflex, where when you stop breathing, it's kind of like, I think, an evolutionary response. When you hold your breath and you dive, your heart rate slows down. And so when you're choking through sleep apnea, you're not breathing, your mind thinks, okay, you're not breathing now. So it slows everything down as well to reduce the amount of, because it's not sure when it's going to get its next breath. So kind of save that energy. Sinopulmonary disease, patients frequently have sinus issues, congestion, not necessarily driving the obstruction, maybe adding on to the obstruction, but gets actually better with CPAP treatment. Somehow, what we're finding is the collapsing of the airways, the repetitive closure and opening of the airways, or even your larger airways of your lungs, tend to elicit an inflammatory response. So we're finding asthmatics as well, who are poorly controlled. Once they get treated with sleep apnea, their asthma symptoms improve significantly. And I'm not only talking about the nocturnal symptoms, but the daytime symptoms as well. So look out for that in this baggage of other multiple comorbidities that we're seeing in patients. Obesity, hyperventilation, which is just a more severe form of sleep apnea, tends to accelerate as the BMI goes above 50. Treatment is pretty much similar to sleep apnea, which is with CPAP. They may need BiPAP though. Pulmonary hypertension is another one. Right heart failure frequently occurs in these patients, sometimes in isolation. And what is driving that is whenever you become hypoxic, the pulmonary vasculature has a hypoxic vasoconstrictive effect. So what it tries to do is when it realizes that oxygen may not be delivered well, it tries to match the blood flow to the areas that are ventilated. So it tries to collapse all the other vessels that are providing oxygen or carrying oxygen around. So what it does is this vasoconstrictive drive causes your pulmonary artery vessels to always constrict. And that's what leads to pulmonary hypertension, and the back pressure causes heart failure. So we have to really look at these patients whenever you deal with pulmonary hypertension, is to evaluate the patient for any sleep issues. How do you evaluate for sleep issues? So what we tend to use, and again, it is not a good tool by any stretch of the imagination. We tend to use this really to gauge patient response. One, if their sleepiness scale was high and they get treated for sleep apnea, what does it change to, or what does it go down to? And then how can we optimize that? And we'll talk more about that in the next webinar next month. But beyond that as well, we're finding that the Epworth Sleepiness Scale really has got a high negative, false negative yield. I have frequently a lot of patients, again, this is self-directed in terms of the patient filling this up. They may misunderstand it sometimes, but number two, a lot of them don't want to feel like they're failing something, or they're like, oh yeah, that might be embarrassing to share. Yeah, that's true. I have a lot of patients who have sleep apnea and don't score anything at all. Some of them score 1 on it. And so this scores on a level of 0 to 3, with 3 being the highest preponderance or the highest likelihood of falling asleep in those situations. There are 8 situations in total, and the scores are over 24. And so in general, it just measures general sleepiness, but not specific to OSA. So a lot of patients, and I'll be honest with you, this is not being cynical, I use this Epworth Sleepiness Scale when I like the score, meaning that if I have a sleep apnea patient and they score 10 and above, or they're 9 and I can call them borderline, I'll use that. But if they score less than that, I tend to ignore that, because I tend to use the other parameters that may be more associated with sleep apnea, the physical exam, for example, the Mallampati score, the other comorbidities that they have, some of the sleep symptoms. So the Epworth Sleepiness Score really is an insurance requirement sometimes, but beyond that as well, it is not the best tool to use. Best tool to diagnose, but like I said, we follow that up as a trend. It tends to be somewhat useful in that situation. The stop bang score, where you look at snoring, you look at T for tiredness, and O for observed apnea, P for pressure issues or blood pressure issues, B for BMI, A for age, N for neck circumference, and G for gender. You score them a score for 1 for each. And if you have 3 or more, then you have a high likelihood of sleep apnea. Again, a very high false negative yield in patients. It does well in screening patients preoperatively, but beyond that, really, I hardly use that. Again, because part of what I do is via telemedicine, so I don't routinely get a neck circumference. But again, the neck circumference, same way with the Malampati score is, when it's large, okay, fine. It doesn't mean that they have sleep apnea. It just increases their likelihood of having it. If they don't have it and they have other reasons, like they have multiple comorbidities, some other sleep symptoms, the awakenings, how refreshed they feel, the nocturia, waking up with headaches, all of this actually adds more value than these scores. This is the Malampati. And so this is a little interesting because we're asking patients, the score, or at least the images show you sticking your tongue out like that. No one sleeps like that. And thankfully I brushed my teeth before I did this. And so you stick your tongue out, but you don't fall asleep with your tongue stuck out. So most of the time what I'll ask patients to do is this, it's a modified Malampati score where you ask them to open their mouth, but keep their tongue relaxed at the base of their mouth. So you do this. I know it may not be clear, but when you can see at least the uvula, so that's a class 1 or 2. And if you hardly can see that, that's a 3. And then going beyond that, when you're just seeing the hard palate, that's a 4. That's a straight 4. Now, you also have to take that into account that I'm still awake, sitting up, looking at you and doing this. Now, can you imagine when you fall asleep at night, when you're laying flat and your tongue flops backwards as well? Another thing we frequently miss is this indentation at the edges of your tongue. That indentation represents your tongue being too big for your lower jaw and actually pressing up against the back of your teeth. And that's how they create that indentation. So again, if you think your tongue is too big for your jaw already there, let it flop back and see what obstruction it causes as well. So that's why the exam usually, again, the neck circumference, the Malampati score sometimes may not be, because you actually have to imagine even a class 1 or a class 2, what happens when they fall asleep? What does it change to? So like I mentioned about the exam, looking at females that have a neck circumference of above 16 inches, these are pretty clear cut again. And I hardly do this because I find, again, by tele, it's a little bit more difficult. So I'll own that. But when you have, facial abnormalities, that's an easier diagnosis than anything else. Most of our patients that we're missing out on, like we talked about, over 30 million patients that don't have a diagnosis of sleep apnea, and that's what's fueling a lot of their multiple medical problems, don't have these. They look normal. They'll complain about a little bit of nasal deviation, and that's about it. They'll complain of some sinus congestion, but a lot of them are you and I walking around. Strains, if they come in and they have strains of right heart strain, go for it. That's also another clue. But again, you'll probably do an echo and find a pulmonary hypertension, and then you should still at least think about sleep as driving that. So then now we've talked about the basic pathophysiology, what drives a lot of these issues in patients, meaning that, what are the pathophysiology in terms of the hypoxia, the elevated sympathetic nervous system, and so on, that drives a lot of their problems, the prevalence as well. We spoke about that. Then we spoke about the assessment of sleep apnea. What words do patients use to describe these episodes? What do they look like in terms of the exam as well? But more beyond that as well, just kind of seeing which patients have these sort of templates or pattern recognition. As you start seeing these patients with multiple medical problems, you should try to figure out, at least trigger in your head, why this patient? Why so much of burden on this patient? And not just go ahead and increase the dose on this and increase the dose on that, because if you can do that, your job is going to get replaced by a bot that can see, well, blood pressure is not controlled. One blood pressure med will add on a second one. But really where your value as a provider is to actually see what is driving a lot of these issues. And that's where you really start stopping problems rather than just patching up problems and putting a Band-Aid on that. Next, we'll go on to the effects of sleep apnea on different patient types. And this is what catches us off guard frequently, but showing you what patients that you may come across that you may need to be aware of to at least think about or trigger the thought of whether this is related to sleep apnea. Patients will complain of sudden awakenings of chest discomfort, and then they get referred to cardiology. Again, I'm not saying you shouldn't, but also why is this happening at night specifically? What's driving that issue at night? Is it the hypoxia that causes the vasoconstriction? Is it the apnea itself that's causing them to wake up because of the choking and so on that they feel? Now, a lot of them will get diagnosed as orthopnea, which is a valid diagnosis, but question is, why the orthopnea? Why orthopnea in this patient? Anxiety attacks. As far as I know, no one has an anxiety attack at night unless it's directly related to PTSD or some form of nightmares. Most patients are not falling asleep or staying asleep and then all of a sudden have an anxiety attack, unless of course they can relate that to PTSD or a dream. These anxiety attacks are driven by the sympathetic drive. So they wake up, they still have these palpitations, they have this sort of hair at the end of the neck kind of raised, they can't catch their breath. It acts like an anxiety attack. It's exactly that. But they get misdiagnosed and they get put on trazodone or one of the antidepressants, anti-anxiety medications. Reflux is also a common complaint. Patients will complain reflux, especially in the middle of the night. They'll wake up with it. And the reason is, as you have an obstruction in your upper airway, what ends up happening is that you tend to breathe against that obstruction. And just like you have, when you suck on a straw and it collapses, the Bernoulli effect, same way when you have a negative pressure here that's created by that, you end up having this sort of negative pressure that's created here that brings up gastric juices. And so it sucks gastric juices up, and that's what causes some of the symptoms. Now, PPIs and so on may mask some of the acidity, but the gastric juices still track up. It's just that it's not as symptomatic anymore. And speaking of associated features, we talked about snoring loudly, but a lot of patients will then embarrassingly try to walk around the issue of snoring, and they'll talk about, well, I don't really snore except when I'm really tired, or I purr. A lot of females actually tend to purr, and that's words not necessarily used by the female patients, but actually their male counterparts or their bed partners or spouses. So they tend to manifest a little bit differently as well. Oops. Headaches. As atypical presentation, patients may also come in complaining of headaches. Again, why? Why this patient? What am I doing? What underlying issues may be driving that? Fibromyalgia symptoms also can be linked to sleep apnea, untreated sleep apnea. Any pain problems as well, especially if you start increasing the pain medications, it's a poorly controlled, poor sleep or worsens your perception of pain. And so that's a real thing. So we need to make sure that in patients who have pain syndromes or chronic pain issues, to evaluate sleep issues. And that's beyond just the idea that, oh, are these patients on opioid and is opioid driving some of the sleep apnea? Maybe, maybe not. But any pain patient that you're seeing, that you start increasing the doses of medications, the pain, they always complain of pain issues, start asking about their sleep. Mood changes, irritability, low energy levels. Patients frequently get misdiagnosed with pseudo depression. Now, depression or mental health has a bidirectional relationship with sleep issues. So sleep issues can cause or worsen mental health issues. Mental health issues can cause sleep issues as well. They both best be treated together to allow symptoms to alleviate. You don't wait for one and then you say, oh, should I treat the other? I frequently will tell my patients, if you have an underlying diagnosis of depression or anxiety, you should or could expect, if sleep apnea is the diagnosis that's driving a lot of this, you start seeing the reduction in your dosages of medications as your mood as well improves. At least if those moods were related to overlapping sleep problems, low energy levels, so I don't have the motivation to do things and so on, a lack of drive, all of this will kind of improve as well. Memory and concentration loss. So I have a lot of patients now coming in with executive dysfunction, meaning that, oh, I can't remember stuff, or I feel like I'm not getting it, I can't focus. So a lot of adults now also getting misdiagnosed with ADHD. So take note of that as well. I mean, again, focus is also related to sleep. Poor sleep can cause you to lose focus. Now, a lot of ADHD symptoms are validly also similar to sleep issues. It doesn't necessarily mean, I'm not trying to debunk the fact that ADHD is a diagnosis. It really is a diagnosis, but at times sleep issues may be making ADHD worse, or sleep issues may be manifesting itself as ADHD issues. So if you treat the sleep apnea, you may cure your ADHD, or you could improve your symptoms of ADHD so you're not relying on such heavy doses of the stimulants. Polycythemia is another thing as well. Patients, because of the hypoxia that they encounter, the erythropoietin gets stimulated and they actually have a higher level. I just had a patient last month with this, I think a hemoglobin of 17 or 18, and which improved after CPAP treatment. Dreams and nightmares are also an uncommon manifestation, but also frequent, especially if it's something that you can't treat. It may be related to the fact that they have these apneic episodes and they frequently shift from different sleep stages. But again, why they actually have it, we're not really sure, but there are theories out there. TIAs are another one related to cardiovascular disease. So keep a lookout for that, especially if such patients start having cardiovascular issues. That's something to consider. Now, women tend to get misdiagnosed frequently because they complain of headache and fatigue and depression, not I'm falling asleep, or not because my partner can't stop elbowing me when I'm snoring and that's keeping me up at night. They're not going to complain of that. So frequently the presenting complaint is different than what we're expecting to hear. But there's also, I'll go into the testing aspect of it, of why women tend to get misdiagnosed. So a lot of women tend to get misdiagnosed and get mistreated with things like Ambien and so on, when the problem really is underlying sleep apnea. And again, like we described earlier, the prevalence, the spike of female patients once they start hitting menopause tends to be the issue that drives that. And so then they get treated with Ambien, or they get treated with some hormone replacement therapy. And we tend to forget about the sleep apnea that's driving a lot of their problems as well. So women, just like women have issues, or not issues, but their presentation is atypical in cardiac disease, it's also atypical in sleep apnea. Heart failure patients, they don't exhibit the usual sleepiness because of the hypersympathetic, hyperadrenergic drive. Because of the adrenergic system being ramped up and hyped up, the sleepiness is not as big a factor. The problem with that is that if you're sleepy and you use CPAP and you're awake, you're sold. You'll use it. You're driven. You're like, my God, this is amazing. Cardiac patients may not get that bang for the buck that they want. They're like, all my friends seem to use CPAP and they feel awake and they're talking about it. And they say it's the next best thing compared to sliced bread. But for me, I don't know. I don't seem to get the benefit. For them is actually it reduces their hyperadrenergic drive. Their blood pressure improves. Their atrial fibrillation improves. Their CHF improves. But they don't feel that sort of like, oh, I'm more awake. So they don't see the correlation with that, unless, of course, you take it long-term and you start saying, hey, listen, look, in the last 6 months, we reduced your blood pressure meds. You haven't had an admission for CHF. You haven't had this of an issue and so on. So these patients tend to get overlooked. Also, the other issue is that when you have heart failure and you have issues in terms of edema peripherally, when you sleep at night and you raise your legs, the fluid accumulation then spreads upwards. That can also worsen your edema. Now, even if we're trying to diurese them adequately, and that might help quite a bit, the problem is that these patients will still always have this triggering of the sleep apnea that triggers their cardiac issues to always be on the borderline of not being well controlled. So consider all of that as well as you see cardiac patients that are not controlled with their CHF. So they'll wake up, they'll complain of palpitations, you'll increase their metoprolol, you switch them over to amiodarone, for example, you'll diurese them even more, but start asking about their sleep. Patients with pulmonary hypertension, I explained earlier, especially sometimes OSA and COPD overlap, or OSA with the worsening form of obesity hypoventilation where you start having hypercapnia. That overlap as well will drive that hypoxia that causes the remodeling of the pulmonary artery vasculature, will lead to you having pulmonary hypertension or right heart strain or right heart failure. And the problem with pulmonary hypertension as well, you won't really see that on echoes as well. The diastolic dysfunction that occurs is also frequently missed as well. So these patients tend to not really show up as clear-cut, oh, heart failure patients or right heart failure patients, unless you do a proper testing and evaluation on them. Patients frequently come in as well for hypertensive episodes. So urgency, emergency, poorly controlled high blood pressure with multiple medications and still poorly controlled. Patients who are young and still have blood pressure issues, or patients who are telling you, doc, I've cut down my wife, I've cut this down, I don't eat fried foods, I don't eat this, I don't eat that, and they still have a high blood pressure. Start looking for what's fanning the flames of their hypertension. Especially in patients with resistant hypertension, we're finding the prevalence of about 70% as well. Same thing with patients with emergency that comes in, hypertensive emergency that come into the hospital. So memory impairment as well, apart from hypertensive emergencies. So patients will say they're forgetful, probably at a younger age, executive dysfunction as well. Pseudo dementia as well frequently gets misdiagnosed, or dementia frequently gets misdiagnosed in these patients. All right, so we spoke about how it affects different patient populations, from our cardiac patients to our dementia patients or patients with depression, trying to figure out, which patient fits that mold. And a lot of patients actually don't fit that mold, especially female patients and patients with cardiac disease as well. They tend to, like I said, have this hypoadrenergic drive and don't really complain of sleepiness, which usually triggers your, oh, I'm fatigued, doc, I'm very sleepy all the time. That sort of prompts a conversation about, oh, sleep, what's that like? but I think we should start asking sleep questions at an earlier stage in our history taking in patients. Now we want to talk about, now we have a suspicion, now how do we order the test? What's next? So sleep testing is growing very quickly in terms of what it does or what it can do. The original was the home sleep, the in-lab study, or called the PSG, polysomnogram. And that's the one that it's patients are always frightened about all their gunk in their hair and the sensors and the EMG sensors and the eye sensors and the chin sensors and the chest wall belt and the fact that someone's watching them sleep. So that's the polysomnogram. You have home sleep apnea testing, and take note, it says sleep apnea testing. It is not an insomnia testing. It's not central sleep apnea. It's if you have a high suspicion of sleep apnea, and that sleep apnea being specifically obstructive sleep apnea. And then we'll dive into a little bit of a digital sleep study. This is what we're doing here as well at my practice. And we're very excited about the fact that how it liberalizes sleep testing. So sleep testing, there's two things that we test for. One is apnea, when you have your airway flow going down to by 90% or more for 90% and going down for 10 seconds or more. And the other thing is hypopneas as well, which is it's a less severe form. So the flow decreases. However, the flow has to be accompanied by a 4% drop in oxygen. Now that's been an issue or a big controversy because the AASM, the American Academy of Sleep Medicine, still stands by the fact, and a lot of us in practice still stand by the fact that 3% is a better drop. The 4% is being driven by a lot insurer requirements. So a lot of patients are getting underdiagnosed with sleep apnea and not getting the treatment they need. And so even though the official diagnosis for many insurance companies is 4%, but a lot of patients get misdiagnosed, and that's a problem. You will see over here, this is what obstructive sleep apnea is. You see the thoracic and abdominal belt on these patients. They keep moving, meaning that there's effort to breathe. However, you find that the flow to the nasal passage, oral and nasal passages decrease. And if you see over here, you'll find that the patient's oxygen levels at 96% start dropping. And that's when you start seeing the 4% drop, for example, to diagnose your hypopnea in these patients. And then you'll see this over here, which is that snort and gasp to kind of wake up and then start breathing again. Now, the sleep study comes up with one number. It comes up with the AHI, or the apnea plus number of hypopneas index. Now it's divided by the total hours of sleep when it's done in a sleep lab. Now it's going to be total number of events divided by total recording time, which is when the patient switches it on and switches it off for the home sleep testing. So the AHI is a very different beast when it's done in an in-lab versus when it's done at home sleep tests. And that's why home sleep tests are frequently misdiagnosing or underdiagnosing sleep apnea. Too many patients have come to me after many years because they were tested in the past and they were told, oh, you only have mild sleep apnea. There's night-to-night variability in sleep, which changes. And there's also this threshold of this 4% versus the 3%, which also misdiagnoses many patients. But also, like I said, how you calculate the index is different. And so many of these patients, for example, if they switch it on and they watch TV in bed and then they go to sleep and they wake up, they may have 9-10 hours, which I frequently see in these patients. They have 10 hours of recording. It's like, how many patients are sleeping for 10 hours at night? So if you actually do ask them, they're going to sleep at night, they're going to bed, switching it on, and then they wake up in the morning, they switch it off, but they're watching TV in between. So the most important thing is to ensure that we don't use the mild, moderate, severe to decide on whether we should treat. We should really treat based on symptoms of the patient, what complaints they had, plus the multiple or comorbidities they have. Use those two things to guide your treatment. The AHI is a severity itself. In my opinion, you should be used as a yes or no to diagnose you. Now, if you're no, it says that the AHI is less than 5 and you got a home sleep test, you should get an in-lab study. All right, so the in-lab study we spoke about, and this is what it tends to look like. It isn't as nice and pleasant looking because a lot of sleep labs have different levels of comfort. But in general, this is what you have to go through to get that. Now, what is the difference between a diagnostic and a titration study? So we'll talk about diagnostic studying first. Diagnostic is to make the diagnosis. Now that's divided into two different forms of diagnostic testing. One is a full night polysomnography where we just let the patient sleep and it's completely observed. Everything that we have, we just collect data on sleep and we don't act upon it. The split night is when we actually say that, or the split night is when the patients have severe sleep apnea, which is, again, the criteria is that if you have 40 respiratory events in the first 2-hour period, they can then put on the CPAP on you to start treating you for those apneic episodes. But that being said, most of the time patients fall below the threshold, so they get a full night's sleep, or at least observed sleep. The split night is to then put them on CPAP. What it does is it helps the patients to then get comfortable with the idea of what CPAP. They may try on different masks as well. So they're somewhat familiar with the idea. They've tried on the nasal one, they'll try on the full face one and kind of get a feel of it, which is easier, especially in older folks, patients who can't do the home sleep test at home. They're also the ones who are less likely to kind of be savvy about changing the mask. So it's good for the tech in that during the sleep study to kind of trial them on different ones. So that's why the split night. I generally order nearly 95% of my sleep studies are split nights. The only time I don't write a split night is if I'm thinking of a underlying neurological problem or some other secondary forms of sleep apnea beyond just obstructive sleep apnea. Now, we also have the titration study, which I'll talk about a little bit, but we also use the titration studies for different, not just CPAP and BiPAP, but other modalities as well to treat obesity, hyperventilation, and also titration studies to treat central sleep apneas. So the titration part of the study is what we do. So this is the indication for the full night polysomnography, which I just described, which is where you want to put them through the sleep study. Now, whether you choose a split night, which I generally choose, and so you can do a split night study in most of your patients if they need an in-lab study, or for insurance reasons, they end up getting an in-lab study. But in general, most of them should be able to get a home sleep study. If you have someone with bad cardiovascular disease, that's when you actually start, or bad neurological disease like poorly controlled seizures, patients with possible neuromuscular weakness, and patients with things like poorly controlled heart failure on oxygen, unstable angina, patients with atrial fibrillation that's poorly controlled. All of this should actually be in an in-lab setting itself. The reason being because they have a high likelihood of central sleep apnea, which is best treated in the sleep lab. Now, the titration part of it is more straightforward, meaning that even if they get they get a home sleep study, but they don't respond well to the thing, meaning that they don't tolerate CPAP, or their tiredness is improved, or their AFib doesn't improve, or they're not just feeling refreshed in the morning, you should bring them in to do the titration study, because you say, I already have a diagnosis of sleep apnea. I need to figure out there's something else going on. So this time what they can do is put the CPAP on from the start of the night and actually see what pressure the patient needs to kind of cause the obstruction to go away, but also look for secondary causes of their sleep disorders. If there's anything else going on in these patients, it needs to be looked at. So you have a diagnostic study, and then you have the titration study. The diagnostic study, most of the time you can't go wrong with ordering a split night study. And for the titration studies, when patients don't respond well to CPAP or the treatment and they got it done as a home sleep test, or even if whatever you got as a full night study and then they went home and they're still feeling tired, you want to bring them in for a titration study then. So you don't need a PSG when you're looking for insomnia. When you're looking for cases of insomnia, as long as the insomnia is not being, it's not like how I mentioned earlier, how some women tend to complain of insomnia more than sleepiness as a presenting complaint with sleep apnea. I'm not talking about those kind of insomnia. I'm talking about patients with true insomnia that they really have difficulty falling asleep, staying asleep, and issues. You don't really need a PSG at that point. That's more history taking. And if anyone, I'll show you my website where we have the recording of the insomnia webinar from last month, then you can watch that and get a better idea of how to deal with that. Restless legs as well as a clinical diagnosis. So same with the circadian rhythm disorders. We've done the last webinar in May is going to be a joint restless legs and circadian rhythm disorders webinar. So look forward to that. Again, patients treated with CPAP whose symptoms resolve with CPAP treatment. You don't need any further testing for that. You don't need routine repeat sleep studies. No one needs a 1-year repeat sleep study unless, of course, their symptoms change. Chronic lung disease, just because you have asthma or COPD doesn't buy you an in-lab study. And again, if you have seizures as a diagnosis and it's controlled, then you don't need an in-lab study. Home sleep testing has got different terms for it. Pick your favorite, but I normally go with HST. It's short. Ambulatory testing, I can't tell you whether it's a sleep lab that's outside the hospital. So I just go with HST is my usual go-to acronym for it. But don't forget, it's a sleep apnea test. And so that's what you're looking for. Is IHST is inferior? I would say not. I think if you have the right patient population, if you have someone as you suspect with sleep apnea, then the HST works well. It allows more patients to get tested. The reason is because it's easier to schedule, it's cheaper to run, so the patients don't have as high an out-of-pocket cost, there's a chances are that they can get the sleep testing kit be sent to their homes, which is great. This is what we do as well. And so there's less of an, oh, do I need to drive 45 minutes? And most of the time, if someone has daytime sleepiness, we will always advise them to have someone drop them off in the sleep lab. Again, as sleep testing in the lab gets reserved for sicker and sicker patient populations, a lot of the times patients will need someone to drive them to the sleep lab. But this kind of makes it harder for you to get tested. And that's what we're trying to do, is allow sleep testing to be much more liberalized. And that's what home sleep tests do really well. So if you have someone who you suspect has sleep apnea, moderate to severe, kind of like that prototypical person, you can go ahead and get the sleep study done. Again, I'll say no matter how much your clinical judgment is, if someone needs an in-lab versus versus a home sleep study, insurance companies drive that a lot of the time. So you'll have to justify an in-lab study. So most of the time I don't fight that battles, but what I do is in my note, I will say high clinical suspicion, low clinical suspicion. I don't really put moderate because I think moderate's a cop out, because a lot of patients will fall, then I don't know what to do. So they're either high or low. And if they're low suspicion, they come back negative, then I say you don't have sleep apnea. But if they're high clinical suspicion for sleep apnea and they come back negative with the home sleep test, that's when I will send them for an in-lab study. So if someone doesn't meet your clinical judgment, it's just the same way. Everyone's got a quick course on false negative testing because of COVID. If your judgment on someone is that I think they have sleep apnea and the test comes back negative, now you know already based on this webinar that home sleep tests will frequently misdiagnose someone with less severe or even no sleep apnea as well, because of the way it's calculated. Again, there's night-to-night variability in these patients. And we find sleep studies routinely will misdiagnose the severity of illness up to about 30 to 50% of patients. So you have this where if you suspect someone has it, follow-up testing is needed. Don't wash your hands of it and say that's it, you don't have it. And we've looked at sleep studies, home sleep studies versus an in-lab, where you do an in-lab study and then you do the CPAP titration in the lab, versus just getting the home sleep test and setting them up with AutoPAP devices. Now, AutoPAP devices will regulate the amount of pressure that you need to keep your airway open. So when it's collapsing a little bit more, it senses the resistance of air being pushed through, so then it increases the amount of pressure delivered. And so that keeps the airway open. It allows the patient to sleep in different body positions and so on, not have to worry about whether they're in REM sleep or non-REM sleep on their side or their backs. The machine itself should regulate that. Now, again, this regulation is proprietary in terms of the algorithm. Some machines do better than theirs. Respironics is one that's repeatedly shown in a lot of studies to actually have probably one of the more superior, or at least the superior algorithm for that. But that being said, having someone tested as an outpatient with a home sleep test and getting set up with an AutoPAP, they do just as well in patients who go to the sleep lab. So that tells you a home sleep test is not an inferior test, especially for the right patient population. But you just have to make sure that, for example, if you set them up with AutoPAP after getting the home sleep test, they don't respond well, they don't tolerate it, or their usual parameters that we're looking at, like sleepiness and nocturia and waking up with headaches or waking up tired, or their AFib is not better controlled, then you should consider getting an in-lab study to be done, or a CPAP titration in-lab, to make sure that the algorithm is doing what it's supposed to in the AutoPAP. But also secondly is to make sure you're not missing out on a secondary diagnosis of a sleep issue or a sleep disorder that may be driving some of their persistent complaints. Now, what's a contraindication to home sleep tests? If you have low risk for sleep apnea, again, insurances will drive this. So as much as I tell you now it's a contraindication, chances are the low to risk, moderate risk is not going to stop the insurance companies from saying, no, they have to go to a home sleep test first. But in your head, you have to know if someone has a high likelihood and they come back negative to proceed with the in-lab study. Conditions that increase non-obstructive sleep disordered breathing, such as central sleep apneas, patients with very bad CHF, patients on oxygen, patients who have high doses of narcotics, neuromuscular disease, all these patients should be done in an in-lab setting. Also, if you're looking at non-respiratory related, like PLMDs, which is periodic limb movement disorders, which can cause persistent sleepiness in patients despite using their CPAP, that's also something that you would need an in-lab study for. Narcolepsy shouldn't be tested that way because it's not a test for narcolepsy as well. It's a sleep apnea test.
Excuse me, it's the last 5 minutes timer.
Okay, thank you. Like I mentioned as well, thank you, Vignesh. Limitations of the home sleep study, technical failure, patients don't know how to put it on and so on. That's one big issue. The underestimation of severity as well, like I mentioned before, of how in-lab studies calculate versus home sleep studies. And a negative study doesn't rule out or cannot rule out sleep apnea, especially if a clinical judgment is that they may have it. The two types, the type 3 and the type 4, are the ones that we're most comfortable using. The type 1 is an in-lab study. Type 2 is usually done in a hospital setting where they have the tech set it up, but sit separately and there's no one really observing the patient. And that's very rarely used, but some hospitals do that, and I think it's great. Type 3 and type 4. Type 3 is what is most commonly available, which is where they have an oxygen sensor. And then I'll show you this. They have an oxygen sensor. They have a oral flow nasal sensor to monitor airflow. They will also have respiratory chest wall belt. And apart from a heart rate, and they have also oxygen sensing as well. So those are the type 3 sleep studies or home sleep test. The type 4, which uses basically one or two parameters, mainly oxygen or heart rate or oxygen saturation. And another thing is they monitor the arterial tonometry or the distensibility of the artery from beat to beat. It doesn't really work well with patients with atrial fibrillation, but it works decently well in these patients. It can capture a lot more data. Now, there are two schools of thought. Most of the sleep studies available are going to be a type 3 devices. Now, what is digital sleep study? It's literally digital, meaning that I can actually, so when I see patients, I will e-prescribe a sleep study on their iPhone or their smartphone. And so they just they go to the email, which I send the e-prescription to, they download the app, they fill in some questionnaires, it walks them to what they need to do at night. They need to sleep alone at night so it monitors their breathing pattern and listens in on your breathing. And what it does is it has an algorithm to figure out whether you're high risk or low risk for sleep apnea. And so this is an easier way. We can do multiple night studies. So the whole idea of home sleep tests where you only get a one night and there's night variability, it gets reduced. But plus we don't have to actually ship anything out and technical failures of it. It's a sleep study done on your phone. You just need Wi-Fi, you need it charged, you need it within 2 feet of your head. You need to make sure that you don't have a pet or a bed partner next to you. But beyond that, you're ready to go. It allows more patients to get tested, more patients to be aware of sleep apnea as their current diagnosis. And we're very proud to actually work with this because a lot of times sleep practices make money from home sleep tests. We don't do home sleep tests. We ship it out, but we work through another company that does that out. We actually don't make any money on the digital sleep study. And the reason is we find that at this point, it is so much easier to diagnose someone than quicker. It gets the patients to what they need, which is treatment. And it shortens the time from actually diagnosis or evaluation to treatment itself. So in a lot of our patients that have smartphones that are tech savvy or even tech able, we use the digital sleep study. Within half an hour of them switching off the sleep study in the morning, half an hour, I get a result, they get a result as well. I generally ask the patient to repeat this three times to take into night variability. And it's impressive. Some nights they get -0 and some nights they're through the roof. So that gives you an idea. If you use a regular home sleep test, which is usually done as a one-night sleep study, they send it back. And if it's one of those days they're tested negative, you miss a diagnosis and you just assume someone doesn't have sleep apnea. So like I said, the prescription that we provide allows you up to 6 tests to be done. So even if you need a titrate to figure out if your mandibular advancement device, which we'll talk about in the next webinar, needs to be done, we can keep titrating that and figure out whether their sleep apnea study improves. Now, we'll just roughly go into this quickly. Multiple sleep latency test is basically a test to see whether patient's propensity to fall asleep. We tend to do this if we're looking for narcolepsy and so on, but this is beyond what we do for sleep apnea. We tend to do this in patients who complain of sleepiness despite being treated with sleep apnea. So we'll bring them in, we'll put them on CPAP, make sure that they are using their CPAP well through the night. We'll make sure the CPAP settings are appropriate. They'll wake up in the morning, and then we'll put them through 5 different courses of, or at least 5 chances to sleep. The first one taking place about 1.5 to 3 hours after their sleep study was finished. So let's say 6 a.m. So we'll start the first MSLT at 7:30 to 8 o'clock or 7:30 to up to 9 o'clock. And we'll give them 5 chances to fall asleep up to late in the afternoon. And we want to see what the likelihood is. Sometimes this is how we make a diagnosis of narcolepsy in addition to sleep apnea in these patients. Sometimes patients get a full night polysomnography and they have to rule out sleep apnea, and then they stay back the rest of the day to get this diagnosis of narcolepsy or idiopathic hypersomnia. So we're looking for the propensity for them to go into sleep, and then more specifically for narcolepsy to go into REM sleep. But like I said, this is a little bit beyond, but I just want to throw in the testing that we have available. Maintenance of wakefulness is another one, but instead of your propensity to fall asleep, we want to see how awake you are. And generally, we will use this for patients who are on treatment, who have public health reasons or public safety reasons, like they're truck drivers or they're pilots, and they had an accident, and we need to make sure that after treatment that they really are awake enough. Then we will do the maintenance of wakefulness, where you have this protocol of multiple times where you just basically have to sit down in a chair, observed, and to see whether they tend to fall asleep. And so they stay awake during that time, and then they pass. So there's this 40-minute protocols, and it's repeated about 4 to 5 times during the day. And like I said, it's to assess response to treatment in these patients. All right, I think I probably have gone over time, but I just want to squeeze those two in. And we've gone through the basic pathophysiology of sleep apnea. Don't forget the repetitive decrease in oxygen, the arousals that causes the sleep fragmentation, and then the sympathetic drive that causes them. So patients with sinus tachycardia, atrial fibrillation, heart rate's always high. Patients, you can see why now with the basic pathophysio, what drives a lot of their multiple comorbidities that start occurring in these patients. We've learned how to assess sleep apnea, not only from a physical exam, but listening to what the patients say, the words that they use, the description, the embarrassment that they have with certain words, or their shyness to reveal that they snore loudly, or the fact that they will not admit to snoring. And sometimes you'll ask them, do you snore? And they'll say no. And then I'll pause. And in the awkward pause, they'll think about it and say, well, I've been told I snore. So some of the things about what words patients use, grogginess, unrefreshed. And like I told you about the unrefreshing sleep may be fraught with issues because patients don't remember a baseline or what it was like to actually get refreshing sleep. So the assessment of sleep apnea is important in terms of how patients describe it. But then in patients that don't describe sleep issues, as a provider of healthcare, how are you digging in deeper? What clues do the patients give you in terms of the baggage they're holding? What are the medical problems that they have? What sort of medical issues that are out of control? And that's when you have to start scratching the surface and going, what's driving this? Why this patient? Why is this patient sitting in front of me with they must have had the worst in terms of genetic lottery. Whatever's the opposite of genetic lottery, that would be that. Because why are they having this and that? And yeah, you can say obesity is driving it, but I mean, this patient, apart from that, is just started to have this issue and that issue and this issue, and I keep increasing my medication. Start scratching the surface, start asking about sleep issues, because they don't need to be those large, obese, or anyone with falling asleep in your waiting room. Those patients can be diagnosed, like I said, by a 5-year-old. No offense to a 5-year-old, but you can be diagnosed by a 5-year-old. And so you really, as a provider of care, you need to start figuring out what's underlying fanning the fuel or flames of inflammatory issues, heart disease at an early age, poorly controlled diabetes, poorly controlled heart rates, patients with anxiety issues, depression issues. You can't seem to get them out of a rut. Every time they come back, you're increasing the medications, they're complaining about something else. So recognizing these patients, subpopulations within your patient population is something that we're trying to get across in this webinar. And obviously we finished that off in a rush with the testing options, but we talked about the PSG or the in-lab study, we talked about the home sleep test, and then we talked about the digital sleep studies, the PSG with the split night versus the full night, and then you have the titration study, especially in patients who have had the home sleep test and get on the AutoPAP. They may need to come back for a CPAP titration in the sleep lab itself. And that's where you have the PSG as a need. Patients with poorly controlled heart failure, neurological issues, on oxygen, heart rate issues are all over the place, unstable angina, those are the ones that you really want in the sleep lab. Everyone else, really, 95% of your patients, 90% of patients can really get a home sleep test, but it always has to be matched with your clinical judgment. So if it comes back negative, like we showed you how the home sleep test frequently underestimates severity, you should not just close the book and walk away. You need to make sure, or walk away. You need to make sure that these patients actually then may need an in-lab study. That's why the digital sleep study really works well, because I can get a minimum of 3 nights done at really minimal effort on the patient, except they have to kick the spouse out or the bed partner out of bed, and the pet, which is usually a harder problem than the spouse or the bed partner. And so, yeah, so we talked about that, and we've kind of wrapped this up. I'd like to thank the American Academy of Sleep Medicine, who's great resources that I frequently use to take care of my patients. And I think that's a wrap. This is our next webinar, a fourth in a series of 5. So we're going to talk about the treatment and management, CPAP, how to troubleshoot CPAP issues, what complaints patients may have, how to think about oral mandibular devices in terms of oral devices that are used to treat sleep apnea. When should we start thinking about surgery? What sort of other options are there, lateral sleeping and so on. These are things that, or the Inspire device, these are all things that we will talk about at the next iteration of this webinar. So if you go to our website today, www.sliip.com, or SLIII, that's 3 I's. That was the cheapest way I could buy the word that sounded like sleep. And so if you go there and you click on there's a website, a banner website banner, you click on that and you can register for the next event. And feel free to share this with your other colleagues as well if you found this up to your satisfaction. As always, thank you. I appreciate your time. I'm going to pause here and see if anyone has any questions before we end this series. So I'm opening up the floor to anyone who has any questions. Maybe not. All right. The other thing, since I have you all captive over here, if you all have anyone else that may be interested in the sleep in terms of the webinar itself, we have kept the webinar in a format that's accessible on our website. So if you go to our website, you go to the resources tab. Under resources, there's a tab for blogs. I'm not sure why it's under blogs, but we're going to change that. You will see a webinar that's a tab for that, and you can just click on that and watch the videos again whenever you want to. All right, that is about it. And like I mentioned, this is the website, and this is the tab that you can use under resources. And this is the tab that you can click on. So if you click on that, you'll get registered. But if you go into resources over here, you check out the blogs page. Now, apart from the blogs that we frequently write about, that's healthcare related, we talked about restless legs and seeing whether that was I'm seeing an uptick in patients being treated with restless legs, but really have no way of monitoring the response, and they get treated with medications that also have potential, a lot of side effects. Are we over medicating our children? That's a new sleep disorder known as restless sleep disorder. That's interesting. We talked about aesthetics and sleep disorder breathing, or how to quit smoking, pulmonary rehab. So a lot of resources here, and one of it being this recording of these webinars that we're doing right now. So this one from today will be listed here. So you just go on there, you can click and watch it and so on. And I think that's about it. So thank you very much, folks, for attending. If you have any questions, please let us know. But we're going to end this right now and take leave. So thank you very much, and breathe well and sleep soundly.